We are very grateful that you have chosen to join us today. This session has been recorded. The recording has begun, and many of you are already finding that chat box. We greatly appreciate that. We ask you to add your name, your organization, and your title there. It helps us greatly. And I would like to introduce myself. We can move to the next slide. And I am Kim Mayo, and I am a program specialist here with the Telehealth and Outreach and Education team at the National Rural Health Resource Center, which is providing the webinar today. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. So today's webinar is being recorded, and it, like I said, will be posted to our website. We would love to see your face if you do have video capability. If you have dialed in from a phone for today's call, you can press *6 to unmute your line if you have any questions or comments. And we also utilize that chat box. And Caleb and myself will be monitoring that. So again, if you haven't already done so, please use that chat box to type your name, your organization, and your title. And you can use that for any questions as well throughout today's presentation. We here at the center, we are committed to diversity, equity, inclusion, and anti-racism. You can learn more and with additional resources from our website to learn more about the center's commitment. It truly is my pleasure to introduce today's speaker. We have Victoria Duffel is with us today. And as I start the beginning of her intro, Caleb, there you go. Caleb can just read my mind. He just knows, he knows what I'm going to say. So those polling questions have been pulled up. There's a few of those for you all to complete. That helps us also to measure how much knowledge is gained. So Victoria is a member of the Health Performance Improvement Practice Unit, and she has more than 13 years experience, including more than 3 years at an academic medical center and more than 6 years providing consulting, words are hard today, services with a health information and technology supplier. She has extensive experience related to revenue integrity and fraud, including contract management, implementation experience for critical access hospitals to large size hospitals with a complex payer mix, daily revenue reconciliation with custom tools, unique revenue leakage, and charge capture technique with fraud, waste, and abuse. Victoria assists clients with reconciling revenue daily and revenue leakage consulting. She is a member of the Kansas City chapter of Healthcare Financial Management Association, and she is a certified revenue cycle representative with the HFMA. She is a member of the AAPC and a certified professional coder. Victoria is a certified fraud examiner and a member of the Association of Certified Fraud Examiners. She is also a Six Sigma Yellow Belt certified, and she is a graduate of DeVry University, Kansas City, Missouri, with a BS degree in accounting, and a graduate of Keller Graduate School of Management in Kansas City, Missouri, with a MS degree in accounting and financial management with the emphasis in certified fraud examination. Thank you, Victoria, for joining us today and presenting on such a timely topic. I don't know if there's a better person, more qualified person out there to do so, and I'll let you take it away. Thanks, Steve, for being with us.
Okay, had to find the unmute button. Thank you so much. I appreciate that intro. All right, well, if you all can see my screen, thank you so much for joining today's remote patient monitoring training. This is the new changes effective in 2021 from the Physician Fee Schedule's final rule. And I have your all's disclaimer on the next page. Kim just showed that a second ago as well. So I'm going to move on to this slide here. This is the agenda slide. I wanted to talk just a tiny bit about chronic care management and transitional care management because they do coincide with the remote patient monitoring. So I thought it'd be a good idea just to talk a little bit about that as well. And then we're going to get into the RPM codes, some of those FQHC and RHC guidelines for billing RPMs. And then I did gather some frequently asked questions that I found scouring the internet while reviewing. So hopefully that will help answer some questions that may be in your minds, but you didn't have time to ask them during the call, or something else came up, or you're just nervous. So don't be nervous. Ask many questions as you'd like. All right. I'm going to go to our next slide, which is our intro to chronic care management, transitional care management, and remote patient monitoring. We're going to start with chronic care management. Chronic care management is considered a critical primary care service that does contribute to that better patient care and health. And to qualify for a chronic care management service, you do have to have 2 or more of those chronic conditions, and those chronic conditions are defined by CMS. There is a link at the bottom of the slide that has a link to CMS's website, and it's the exact same list, but if you wanted to see it from CMS, you can go to that link. We will talk about those chronic conditions in just a second, though. I'll show you that list. The next item on this slide is this service is not typically face-to-face, but I didn't want you all to confuse a not face-to-face service with a telehealth service. The chronic care management codes do not leverage the 95 modifier and the FQ modifier for telehealth services. The big difference between this and a telehealth service is the consent from the patient and the cost sharing involved in it. There is none of that with chronic care management, so it wouldn't technically be a telehealth service. I wanted to make sure that you all understood that. Next, we have this chronic care management service does allow eligible practitioners to bill at least 20 minutes of care per month. Those eligible practitioners are going to be your physicians, your physician assistants, nursing, those clinical nursing specialists, your nurse practitioners, and those certified nurse midwives. Well, they are able to bill out those 20 minutes of that care coordination per month. Now, it would be like just the charge when we get into the individual CPT codes, it'll make more sense here. And then the idea of chronic care management is to help reduce that geographic and racial, ethnic healthcare disparities. Oh, any questions over chronic care management before we move on to what the chronic conditions are? All right. Oh, we all know out of the ICD book, there are hundreds and hundreds and probably thousands and thousands of conditions listed in the book as chronic. Just because the ICD book says it's a chronic condition does not mean it qualifies for a chronic condition with CMS. So CMS has provided this nice list, and there's another link to chronic care management at the bottom of this slide, but these are the 21 chronic conditions CMS considers chronic conditions. And to qualify for chronic care management, you have to have at least 2 of these to use the service. So I've reviewed many of this entities or facility, like this company, the NRHRC. I've reviewed lots of your all's encounters, and the big ones I've seen is probably alcohol abuse, cancer, chronic kidney disease, COPD, depression, heart failure, hyperlipidemia, hypertension, and then schizophrenia, psychotic disorder. Now, those are just the ones that I've seen, but I have seen patients with those conditions. So you all do see patients that qualify for these. So this is really good for you all. All right. Any questions on these chronic conditions? All right. Well, the big question, what are these codes and who can bill them? Before I get too far into this, when I started reviewing these chronic care codes, I noticed that there's complex chronic care management and then chronic care management. So the first thing I did was I want to know what the difference between these two are. There's only one piece that's different between one versus the other. So I'm going to go through the comparison. So the list so far, I'm going to go through, it covers both complex and then just chronic care management. So both sides of it, patients have to at least have the chronic condition for 12 months or with death. The significance, there is a significance of death, acute, exacerbated, I'm bad at pronouncing words today too. And that would be the next one. Functional decline. And then here's where it makes them different. The complex has to have a moderate or high complexity MDN, where the chronic care management does not. So I'm hoping that helped out. I can say it again if I need to, but that's the big difference. Is the complex chronic care management is looking at the MDM of a moderate or highly complex, versus chronic care management is looking at everything else. Hopefully that made sense. Well, now that we have a better understanding of what complex versus the non-complex is, let's get into these codes. So the first two codes are going to go together, the 99487 and 489. 487 is the first 60 minutes of a complex chronic care management service. And this is clinical staff time that has been directed by a physician. And then the add-on code to that is each additional 30 minutes. You'll see the code come in 99489. And I do apologize. I saw this little chat come in, so I want to make sure I'm monitoring that. Okay. So we've gone over 487 and 489. Those can both be billed by a physician or clinical staff. 99490 and 99439 are those chronic care. The 490 is the first 20 minutes, and the each additional 20 minutes is the 439. And that's going to be the chronic care service visit with a clinical staff time directed by a physician. So again, the physician and the clinical staff can bill for those two codes. Any questions on this slide? All right, well, let's move on to our next slide. We have 99. This is the chronic care management service. This is at least 30 minutes of physician time. So the physician is the only one who can bill for this code. And then we have G0506, and that is the comprehensive assessment of and care planning by that physician for those patients needing that chronic care management. And that's going to be that physician, again, only billing those codes. So that is chronic care management, just a very high overview of what it is and some billing behind it. Before we move on to transitional care, do you all have any questions for me? All right. Let's move on to transitional care. Transitional care is a bit smaller. There's only two codes for transitional care. Transitional care management is the management of transitional care from an acute or certain outpatient stays to a community setting with face-to-face visits. This transitional care is once per patient within 30 days of post-discharge. So this is that care from your patient was in an acute hospital and now they're going to some other community setting with face-to-face visits. Maybe they're going home and they're going to see a physician or a provider for face-to-face visits after, and it's that care transitioning from, and I have a list of those settings. Those settings are going to be like an inpatient acute hospital, inpatient psych, long-term care, skilled nursing, inpatient rehab, hospital outpatient observation or partial hospital stay, or a partial hospitalization at a mental health. So if you're transitioning from any of those hospitals to maybe home where you're going to have a community setting, then this transitional care could help there. So getting into the codes for transitional care, 99495 is the communication within 2 business days of discharge. And that communication can be flexible, could be email, phone, direct contact. The MDM of at least moderate. And then there's a face-to-face visit that has to happen within 14 calendar days of that discharge. And then very similar to 99495, we have 99496, where communication within 2 business days. That's again, email, phone, and direct contact. The MDM of a high complexity, and a face-to-face within 7 days from discharge. And that's calendar days. That is the transitional care management. It's not very big. It's a very brief period. We got that 14-day window of care happening within that 30 days of post-discharge. So does telehealth count for face-to-face? And Kimberly, you might need to elaborate just a little bit more. When it comes to the 2 days, that can be done by email, phone, or direct contact, but the face-to-face does have to be face-to-face. It would not, I guess, if hopefully this answers your question, those would not be telehealth visits. Those would need to be face-to-face. Thank you. Yes, those would have to be in person. Hopefully that answered your question. If it doesn't, let me know. All right. Any other questions on chronic care management or transitional care management before we get into the remote patient monitoring? All right. Well, feel free to ask them throughout the presentation if you come up with any. So now we have remote patient monitoring. Per CMS, the RPM stands for remote physiologic monitoring. However, remote patient monitoring has been used interchangeably. So when I saw that the first time, it took me a while to see that, because CMS called it one thing and other people call it another thing, but it's an interchangeable word, so no problems there. But just wanted to let you all know that if you do hear remote physiologic monitoring, it does stand for the remote patient monitoring as well. The remote patient monitoring is the development and management of a plan of treatment based upon that patient's physiologic data. For the PowerPoint, I did get that emailed out a couple days ago. I think Kim might be able to get that out to you, but if not, I could make sure we get it sent out to Caleb and Kim at the end of today.
Yes, we can put it in the chat box as well. We can drop a link. So be looking for that. Great.
Thanks, Kim. All right. So getting back to our remote patient monitoring. Getting back to the RPM, it's the development and management of a treatment plan based on the physiologic data. So we will get into that with the CPT codes, but it's taking patients' diagnoses and using devices, FDA approved devices, to determine, where they are currently and where their goals are, and then working towards those goals using the physiologic data. Oh, services involves the collection and analysis of that patient's data, and it's obtained from those devices. And then the treatment plans are developed based on those devices, that physiologic data. And then it's management for chronic and acute illnesses and conditions. So that's kind of a new little caveat, as the other items we were seeing were more on those chronic condition sides, where remote patient monitoring does chronic and acute, and it doesn't have that chronic, I'm only looking at these specific 21 chronic conditions. So that's also not defined here as well. It's all chronic, acute illnesses and conditions. All right. Are there any questions on just the basics of remote monitoring before we get into those remote monitoring codes? All right. Let's go ahead and dive into our first RPM, remote patient monitoring code. It is 99453. This is the remote monitoring of that physiologic parameters. This is the initial setup and patient education to use the equipment. And up in the description, that could be weight, blood pressure, pulse oximeter, respiratory flow rate. You could also have like a glucose monitor. I mean, there's lots of devices that can help capture that physiologic data. So this code is used to report the initial setup and education of those devices. You would only use this code once per episode of care. And I thought it would be good to know what episode of care it means in this scenario. So the episode of care is the beginning when the RPM service is initiated, and it ends when the target goals are obtained. So if you have a weight loss goal of 75 pounds and you start in January and in October, you've reached your 75-pound goal, that is the end of your care. So in December, if you start a new episode of care, you could then have another 99453. If you have a new weight loss goal, or if you developed heart problems or blood pressure or respiratory issues that they want to now monitor, they can create another episode of care for you. Oh, this code can be billed once, regardless of the number of devices. So if you have a scale and a pulse ox and respiratory and glucose, you can only bill this once to cover all of those devices, the setup and the education on those. You would not report this code if monitoring less than 16 days. You would not report this code for services that are included in other codes. So if you had continuous remote glucose monitoring, the 95250, and that's been a code and it's continuous, and then you're going to do the RPM on it, you wouldn't charge these codes to set that up for the glucose monitoring. You're already doing it. So you wouldn't do it twice. And then this code 99453 can be billed in the same month as your chronic care management and your transitional care management codes. And that would make sense. I could see a patient discharging from an inpatient stay to home and have that, they have the chronic care condition and they're transitioning to, so you'd have those two codes, transitioning to home and to a local provider to help monitor this. And then they put you on an RPM program to help with your chronic condition from your hospital stay. So I can see all of these codes being built together, so that would make sense. Are there any questions on CPT 99453? All right, well, let's move on to CPT 99454. This code is for the remote monitoring of the physiologic parameters. It's the initial device supply with daily recordings, programmed alerts, transmissions. Oh, taking that into more layman's terms on that, this code is used to report the monitoring services, the device, If I have a glucose monitor and it is checking every hour, that's going to be, it's programmed to record it. And when it transmits, if it transmits every night to my physician, that transmission, this is where that's covered. Programming alerts, let's say my physician wants to be alerted every time my blood pressure goes above 200, and there's a programmed alert, this code covers that. Now that's what we're going to see here. So it's going to be your device, the supply for the device, the recordings, the programming, the transmissions, and this is a 30-day code. So we would only see this billed once every 30 days, and it would only be once even if you had multiple devices. Again, you would not report this if monitoring is less than 16 days. You do not report this, you do not report this code with those services that can be included in other codes, like that glucose monitoring for 95250. And that we could see this code being billed with the chronic care management and transitional care management. So it would be okay to see those billed together. All right, so that is 99454. Are there any questions on this code? All right, well, I'm going to move on to our next slide. We have 99457 and the add-on code 99458. So 99457 is the remote physiologic monitoring treatment management services. This is that clinical staff, your physicians, your qualified healthcare professionals. It is their time that they are interactive communicating with that patient or caregiver about their health using the remote physiologic monitoring. The 457 is the first 20 minutes, and 458 is the additional add-on, additional 20 minutes. So the 457 would be reported each 30 days, you get one. And then if there's that additional 20 minutes, you'd get your add-on. And then you would only report it once, regardless of the number of monitoring modalities performed in that given month. So it's just one time. Both codes do require a live interaction communication with that patient or caregiver. And I do want to provide you with the CMS clarification on what they mean by interactive communication. So per CMS, they did clarify that interactive communication for the purposes of 99457 and 99458 involves, at a minimum, real-time sync two-way audio that is capable of being enhanced with video. And again, in layman's terms, that really means you can talk to them on a telephone. And if you have the ability to do video, you can do video as well. But that is their interactive communication. That means that email wouldn't fall in here or text message would not fall in here. And then this code also can be billed with your chronic care management and your transitional care management codes. Are there any questions that I can answer over 99457 and 99458?
Yes, Victoria, this is Lee Chastain, West Louisiana. It seems as though that you're double dipping if you're doing the first 20 minutes on CCM and the 20 minutes here. It seems like that's the same interaction.
So it wouldn't be, and we can walk through this. So you're saying that if you're doing the chronic care management the chronic care management here, and then each additional elsewhere. And if anyone else can correct me, I'm happy to. So I can see that. Let me talk through this. I want to say this piece of it is monitoring the treatment with the physiologic data, where the chronic care management is more of, I'm managing your prescriptions, I'm managing how you're reacting to the prescriptions, where The remote patient monitoring is more of, we have your physiologic data based on this information, this increase, we want to try this. So while it can be connected, it's not the same. And I think that's why, and I can look into this and just double check, but I believe that's why they say you can bill them all together in the month. I don't know, did that make sense?
It does. So let me be a little more clear. If in fact you're doing CCM and you have monitoring a patient, does not that interaction with the patient also count for CCM, because it qualifies under that definition, if I understood it correctly?
8. Let me look into that a little bit more on you for you on that. My thoughts were when, and we can go back to the chronic care management slides. So it's the primary care services that contribute to better patient care of the 2 or more chronic conditions. So that could be weight management. And I get where you're saying, where it could be double dipping, and I see it. CMS is letting you all bill those together, but if you had like a scheduled appointment time that you go in for medication management, I think the chronic care piece is more of, we're reviewing this. We know you have chronic conditions. We're going to run some labs. We're going to do, medication. We're going to, try some other things. So that's the chronic care side, where when we look at the remote patient monitoring, that's more of, we are looking at the data that you provided physiologically, and we're saying, okay, now we're looking at your glucose numbers. These glucose numbers didn't have anything to do with the chronic care meeting we had with the medication, but both of these meetings together could impact on how prescription management is done and how reactions are done. So I could see in the future where they may not allow you to put these 2 together, that the 2 visits could be independent, but work on patient care together. And I think that's might be the angle it's coming from. But I can do some research on that.
Thank you.
Okay, yeah, no problem. Hopefully that made sense. Like, that's the thoughts I've had when I thought about these being put together in that way. Okay, well, this is probably more because we wouldn't be looking at, or physicians wouldn't necessarily be looking at prescription management when it comes to this part. This is we are monitoring your physiologic data. Why is this happening? And getting into that treatment plan. And that's also the other part, is this is your treatment plan. These are your slides for your treatment plan, where the other one is that like high overview chronic care management, I think.
Okay.
And let me look, there's a note in here. So for a RHC, when we bill them together, do we roll them up to one line? So that is going to be, we have a slide in here that talks about RHC and FQHC billing for chronic care management and remote patient monitoring. So Michelle, I'd like you to hold on to that question, and when we get to it, and let me know if you still have a question on it, if that's okay. Let's see. Oh, cool. All right. Oh, but yeah, I'll definitely look for some more information. If I find anything else out about that 99457 and 458, I will update you all. But as of right now, you can bill your chronic care and your transitional care management with these RPM codes. Oh, that was a lot. Okay, let's move on to the 99091. I have 2 slides for this one. 99091 is the collection and interpretation of this physiologic data. And this is the first dot on here is the CPT description. But really what, in layman's terms, that is saying is this code is used for the collection and interpretation of the data that is provided, that physiologic data. It does have to be reviewed by a physician, a qualified healthcare professional that is trained, though an actual physician would be doing this, not a clinical staff person. 99091 is a minimum of 30 minutes, and you get minimum of 30 minutes each 30 days. So CMS has provided the little breakdown below. They feel that you need to spend a minimum of 30 minutes, but they total about 40 minutes of a billing provider going through, and they provide a breakdown. They feel 5 minutes of pre-work chart review, where you go in and kind of review the chart, like, okay, this is my patient. I find them in the EMR. Here's their conditions and everything. And okay, now I know who I'm talking about. Then we go into the 30 minutes of the intra service work, where you're analyzing the data. You're going, okay, this is her glucose through the month. It kind of roller coastered, and interpret what you're seeing. And then the last 5 minutes is posting that into the EMR. So that would be the flow that we would see for 99091. It continues on that the documented time may not be performed by that clinical staff, but it does need to be performed by that billing physician. The treatment plan documented in the EMR should have the diagnoses, your short and long-term goals, devices that are being used, amount of devices, modalities utilized, and then responsibilities of the care team members. And this gets into, do you want them to be alerted every time X happens, if your numbers fall below here, if your pulse ox drops below 70 or whichever. So like, that's where you're going to see the responsibilities of the team. That's documentation. This code does not require any communication between the patient and the provider. It is purely for documenting what data has been received. And then that kind of leans back over to the question that we were just asked a second ago about 457 and 458. This visit here also entails going over their goal plans. The CCM visits, the chronic care management service visits, it has that going over your chronic care, your medications. Well, the 457 and 458, that's the time where they talk about your plans and your goals and how you're meeting them, in addition to how your other chronic care visits. So I think that might help separate out why you can bill for both visits and it's not currently considered double dipping. Well, hopefully that added some insight there. And then the 99091, it does say this cannot be billed in the same month as CCM or TCM. So that's a little different. I'm not sure the reasoning behind why, and I can look into that if you're all curious, but CMS just has it listed as you cannot bill 99091 in the same month as CCM or TCM. I guess my thoughts would be on that is transitional care makes sense, because if you're transitioning out of one facility and going somewhere else, that's usually a 30-day period. That's what the transitional care really is moving from one to the other and making sure everything's connecting. Doctors are talking, notes are flowing, and everything is good for the patient. If you're collecting data and analyzing it, you have at least 30 days worth of data. So I wouldn't expect to see a 99091 in the same month as a transitional care. So that makes sense to me. The chronic care management code, that one, I'm not sure why they decided it isn't okay for the 99091, but it is okay for the 457s and 458s. So I'll look into that one too as well. But that is their ruling right now on that. Before I move into a recap of the codes, do we have any questions so far? Any other questions? Y'all a second. All right, well, let's go to our next slide. So these are the 5 RPM codes that we just talked about. I listed just a really brief description just to note what they are and then who can bill for them. So 453 is that initial setup, patient education of that equipment. 454 is that recording, that transmission of data for that 30-day period. 457 is that 20 minutes of monthly monitoring interaction. And 457 and 458, I would expect them to take place because you probably wouldn't want to go more than a month talking with your patients about it. But this is a 20 minutes a month of the monitoring interactive communication with your patients on the data that you've been receiving. Has their plan changed? Have they improved? Has a new problem been identified? So that's what 457 and 458 are going to be. And then that 99091 is that collection and interpretation of that physiologic data. And then in column, I guess the third column, we have physician and clinical staff can code the first 4. And then the physician can only do the 99091. Any questions on this high overview? All right, let's get into the RPM guidelines for rural health clinics and FQHCs. Oh, yeah, let me get this question from Kimberly real fast. It says, I know of a site where a PharmD is performing the step of collection and interpretation. Do they count as a physician? It has to be if we go back to the description in the CPT book, it says the physician or other qualified healthcare professional qualified by education, training, licensure, regulation where applicable. So if it's a pharmacy doctor, I would think that would be fine. Like it falls into your a qualified healthcare professional by education training. Sure, no problem. Can you tell me when RHCs became eligible for RPM? That's a great question. And I will let you know that is the first line of my RHC and FQHC guidelines is RHCs and FQHCs cannot bill for RPM codes. They are supposed to be using the G0511s, as this was added to cover these services. G0511, my next slide goes into that information of how the code is used. It is 20 minutes or more per month, coordinating patients' chronic care or behavioral health services. That would not be considered a telehealth service, and it can be billed by physicians, those nurse practitioners, physician assistants, and certified nurse midwives. Let's get into this code just a little bit more. This is the description from the CPT manual or the book. So your RHCs and your FQHCs only, they are the only ones allowed to bill this code. It's general care management, 20 minutes for those RHCs, FQHCs on the chronic care management or behavioral health services. And then as of 2022, the rate was $79.25. I hope in the future that RHCs and FQHCs will be able to bill RPM, but as of right now, this is the only code that can be billed. Are there any questions? I have my next slide jumps us into the frequently asked questions, and we get into more of our RPMs. Yeah, Michelle, if you want to go off mute. Or feel free to type it in, whichever.
Let's see, can you hear me?
I can, hi.
Awesome, thank you, hello. So my question is, thanks for taking my question. The question is, on the previous slides, not in an RHC, when we had different CPT codes, that the question was, are we double dipping? I understand our G code that we use for RHC, but if we're providing those same services as non-RHCs that add up to our minutes, can we include those minutes in our time, or is it just the G code for anything above 20 minutes, regardless of the work and the amount of time that we do for the patient that month?
Okay, so you're referring to the G code, right? The 20 minutes or more for the
Right.
G code? Okay.
Yep. So I understand we're doing the G code because we're an RHC, and I understand that we'll put the modifier behind it, and that it's for 20 minutes of more of time. Is that whether we spend 20 minutes or 200 minutes? Doesn't matter.
It doesn't matter. It would be 20 minutes or more. So it would be one code, no extra units, just one.
And so when we're calculating the 20 minutes, are we allowed to include the time for that previous slide when we were talking about the double dipping services? Are we allowed to count both of those types of services if we're doing those types of services into this 120-minute claim?
Michelle, that is a great question. Let me look into that for you. You said G0511, and then you're looking into the CCM, and can you bill the G0511 along with your CCM codes?
That's right. Well, I think our CCM codes are rolling up to the G0511.
Okay. I mean, I would think the G0511 would be billed in lieu of those CCM codes because they cover the chronic care services.
Right. And I apologize. What was the other section of codes that are not CCM code related?
Oh, the transitional care?
Yes. Yes. So if we're providing CCM and traditional care, and what we heard earlier was that we could bill both of those services, my question is, are we allowed as an RHC to combine both of those services onto one G code for our minutes?
I think that's probably what you'd have to do. If you want, we could probably take, and we could maybe talk on offline about this, and we can always take this back and let the group know the outcome of it. I wouldn't mind having a little bit of time to research this and have you dig into that question a little bit more, because I'm getting lost just a little bit on where the question is going. And I can try to confirm it one more time with you. So you're an RHC and you're providing chronic care management services to a patient using the G0511 code. And you're wanting to know, okay, and then you're wanting to know if the transitional care management code is getting rolled into the G code, or if you can bill it separate.
That's correct. That is
Okay.
absolutely the question.
Oh, okay. And I'm just making a note. What I am going to do is take that question back as well and see if I can find some documentation from CMS and how they explain that. If that
Okay,
works
perfect.
for you
Thank
all,
you.
and I can reply to Kim and let her know the takeaway questions we have. So I know what needs to be answered as well.
Great.
So-
Thank you very much.
Yeah, no problem. So far I have the question you all have for the chronic care versus RPM. And what I'm going to do is try to get a more distinct description of what's being done in one versus the other and why there isn't any overlap. And then I'm going to clarify if RHCs can bill the G0511 and the transitional care management. So those are the two outstanding questions that I have. Are there any other questions you all may have? All right. Well, I would like to go into the frequently asked questions and just kind of wrap up the rest of today's call with some of the questions out there on RPMs and what other people around the world have been asking about RPM management or RPM. So the first question is how are patients tracked? So the FDA has these devices, FDA approved devices for the telemonitoring services. For the RPM codes to be used, the devices for telemonitoring services need to be FDA approved. And these devices can allow continuous collection of that physiologic data. The ways it can be transmitted is either Bluetooth or cellular. Cellular is going to be better because it's that continuous, where Bluetooth is going to be the, I have my device, I'm going to put it up to the machine and it's going to scan my data, and then the provider will have it to review at their time. For the cellular, there are ways to get alerts. We talked a little bit about that through the presentation. If there's any irregularities, it will alert the patient and provider. I have a friend that has a She has type 1 diabetes and has a little pump, and it does cellular data to her cell phone, and it alerts her if her blood sugar falls too far. So her phone will go off and alert her. Well, pretty interesting. There's also third parties that can be involved to help monitor this data. So if you have like maybe a very sick patient that needs quite a bit of monitoring, a provider could have a third party monitor the data when the provider cannot. Like they may be receiving alerts, but they're not going to be available 24/7 to monitor that. So third parties can get involved as well. And the programs can include subscriptions to monitor admit and discharges and alert the providers of those hospitalizations. Well, that's pretty cool how it can track a patient and just kind of, for the sake of the patient, the health and care of the patient, you can follow them and make sure everything's being kept an eye on. You can have certain alerts put in if your blood sugar goes too high or if your pulse ox goes too low or your blood pressure. So a lot of monitoring. Are there any questions or comments on how our patients tracked? All right. Let's go into, does RPM integrate into my EMR? Oh, this first might be a little misleading. It says devices can easily and automatically be integrated into an EMR. That is possible. Not all EMRs may be sophisticated enough. I can't say that every EMR would be capable of integrating these devices, but RPM is a pretty remarkable type of software, a great idea to help with patient care. So I can definitely see EMRs going in this direction for sure. I can see that this could help reduce staffing costs where patients won't have to constantly enter in data, or if a patient comes in and says, yeah, I've been monitoring my glucose levels, here's a list of paper, and do you like scan it in and put it into their EMR? Or would it be easier to have a machine track it and log it for you? So training costs could go down, solution adoption. And then device communication to the EMR can have a consistent connection or a constant connection. That cellular connection is going to send that constantly. We'll send you live alerts. Or you can schedule that communication with Bluetooth where you just scan the device and the data downloads. So yeah. Any questions or comments on this frequently asked question? All right. What specialties can benefit most from RPM? This is pretty not surprising. I can definitely say cardiology, of course, pulmonary, gastro, bariatrics, primary care, all of it makes sense. Is my question to the group, is there anything on any specialty not on this list that you think would greatly benefit from something like this? Maybe short term, but maybe OB, like I'm pregnant, I'm having this. Yep, they definitely, Kimberly. Yeah, absolutely. Like that would probably be a good one short term to monitor blood pressure, maybe somebody who's high risk pregnancy or something. All right, let's go to our next slide. What disease states benefit most from this? Now, this is hard because I feel like a lot could benefit from this, but those top ones, absolutely hypertension, absolutely obesity, congestive heart failure, COPD, diabetes, like these are really great states that can benefit from this program. Another throw out to you all, can you think of another disease state that you think is like, yeah, that definitely can? Oh, let's see. Diabetes is on there. Yep. Going back to labor, like that's being pregnant. That's definitely one. People can get so sick being pregnant. So monitoring your pulse ox or blood pressure, failure to thrive, underweight. That's a good one. Being underweight. Oh, definitely. All right, let's go to our final question. What are some benefits from RPM? I mean, we've talked about a lot. I mean, I don't know, you could probably just sit there and think about it without having to do any research to see the benefits from the RPM program. But first one on here, improve management of acute and chronic conditions. Yep. Reduce hospitalization and readmissions. Well, if you're monitoring and somebody has been not feeling well for several days, maybe even several weeks, if you are monitoring their blood pressure or their pulse ox, you'd probably find out the problem before they have to be hospitalized. So yeah, I could agree with that one. Reduce hospital length of stay. Well, if you're having to go in, I mean, reduce the hospitalization length of stays. I can see that. Lower overall healthcare costs. If you're catching stuff before you have to go to the hospital, that makes sense. Increase patient adherence and engagement. I could see that if you're actively showing data. I mean, I'm a pretty data-driven person. So if somebody showed me a chart and they said, here's your weight loss and gain for the entire year, I mean, I might be sad looking at it, but I'm definitely going to be more engaged than seeing that and say, you know what, if I did this, it's going to go down. So seeing, people are more visual, so seeing probably would help. RPM enables older and at-risk individuals to remain at home longer and delay or avoid moving into skilled nursing. Well, I mean, if a reason somebody's going into skilled nursing is to monitor your pulse ox or blood pressure and it's able to be done at home, they might be able to stay at home a little bit longer. And then last, I have RPM helps reduce the risk of infectious disease exposure, such as COVID, for patients, providers, and healthcare workers. So actually another really good one. And while I go through that example, if you have any more that you think would or any reasons why this is a benefit, that yeah, definitely. I mean, very common sense. If you don't have to go in to check your blood pressure, or I think my pulse ox is low, or glucose, and you can see it at home and maybe make a phone call to your doctor and talk to them, avoid going in and exposing yourself. Definitely would help reduce that. So lots of really great information. I have a couple takeaways to answer back, but that is the end of the RPM training for today. Are there any other questions I could help answer or put some research in and bring back responses to you all? All right.
While we're waiting for folks to either formulate a question, or we're gonna we'll launch that post polling so that we can get a comparative of what you've learned. Thanks so much there, Caleb. If you all will just take a moment to answer those couple of questions, we would greatly appreciate that. And Victoria, we greatly appreciate your guidance and leadership on this presentation. I know it was great information. As we did mention in the beginning, it will be recorded. It has been recorded, and it will be posted to our website. And we'll get you all linked to that once that is processed and uploaded, which takes a little bit of time. But we greatly appreciate you all being here, and especially you, Victoria and Paula, and the Forvis team for your research and dedication to putting this together. We'll definitely follow up on anything that was posed today that we need to get back with you all on. We'll be happy to do that as well. So thank you all so much. We're getting some great feedback here, great presentation. Thank you for the information. We appreciate your time and effort and energy for the September 1st presentation. So if anybody has any questions, feel free. We'll give you just a moment. We have 1 minute till the top of the hour. And otherwise, thank you all for being here. And thank you, Victoria and team.